Very good evening, everyone. Greetings from Chennai. Today, I'm going to talk about recurrent hypoglycemia in type 1 diabetes. So after briefly discussing about hypoglycemia, we will be moving on to our case discussions. And hypoglycemia, why it is important is that it is a major limiting factor for preventing optimal glycemic control, and it definitely imposes a psychological morbidity to the patients and as well as parents. So ISPAD in its recent guidelines has said that reducing the incidence of hypoglycemia by monitoring hypoglycemia as one of the key component of diabetes care. So coming to definition of hypoglycemia, there is no single numerical definition of hypoglycemia that can fit for all patients and in all situations. ISPAD in their recent guidelines in 2018 has proposed three categories. The first one being clinical hypoglycemia alert, in which the blood glucose falls less than 70, and this has been identified as the threshold value for treating hypoglycemia. And the next category is clinically important or serious hypoglycemia when the blood glucose falls less than 54 and the child starts showing symptoms due to defective hormonal counterregulation and impaired awareness of hypoglycemia. The third category is the severe hypoglycemia, which is defined as event associated with severe cognitive impairment like loss of consciousness, coma, and convulsions. So how common is hypoglycemia in type 1 diabetes? It is very difficult to say. In the DCC trial, it has been shown that in the intensive therapy arm, the hypoglycemia is threefold higher. However, in the recent studies, in the registries from Western countries have shown that the incidence of severe hypoglycemia is coming down like 3.3 to 7% per 100 patient years due to the use of analog insulins, effective hypoglycemic educations, etc. However, in India, the incidence is still higher. ICMR database is showing hyperglycemia to be about 11%, whereas the recent SGPJ Lucknow study has shown severe hypoglycemia to be about 22.8%, and the incidence is even higher in children less than 10 years of age. So there is definitely a transient cognitive dysfunction, structural and as well as functional abnormalities of the brain, increased tendency towards epilepsy and negative psychosocial consequences following hypoglycemia. However, in the EDIC study, it has been shown that there is no decline in cognitive function in the long term, even in the youngest of cohort. And it is also quite intriguing to know that the same neurological changes is also observed in children who had chronic hyperglycemia. So this has led to the proposal of diathesis hypothesis, in which the younger age at onset, decay at presentation, severe hypoglycemia in children less than 6 years of age, followed by a chronic hyperglycemia, will form a neurotoxic milieu, and that can lead to a sequelae following hypoglycemia. So coming to physiological response to hypoglycemia in children and adolescents, even before the blood glucose falls less than 70, there is inhibition of endogenous glucose production in the body. This will be supported by glucagon, adrenaline, and growth hormone release when the blood glucose falls less than 70. And when the blood glucose falls about 54 milligrams per cent, which is severe hypoglycemia, a cortisol release occurs, and the child will start showing autonomic symptoms. When the blood glucose falls further in the range of 40, neuroglycopenic symptoms occur. But what happens in type 1 diabetes is that there is no way that the body can decrease the endogenous insulin production. And we also know that the counter-regulatory glucagon hormone response is poor in type 1 diabetes, even at the onset of diabetes. So this leaves the hypoglycemic child to be in the hands of autonomic responses. So by the time the child starts showing autonomic symptoms like shakiness, palpitations, sweating, etc., it is like hypoglycemia begets hypoglycemia, because the autonomic responses come only when the blood glucose is in the severe hypoglycemic range. And this leads to hypoglycemia unawareness, as the mild hypoglycemia symptoms are usually gone unnoticed. Even though it is theoretically speaking, it is possible to reduce this unawareness, it is practically little difficult to do it. So coming to clinical features of hypoglycemia, I want to highlight this behavioral signs and symptoms as well as the non-specific symptoms like hunger, headache, nausea, tiredness, irritability, inconsolable crying, like that, to be the classical symptoms of hypoglycemia in a very young child and as well as in infants. Coming to risk factors for hypoglycemia, always we have to think about modifiable risk factors like excess insulin, low food intake, exercise, sleep, and alcohol ingestion. And certain risk factors we have to avoid, like impaired awareness of hypoglycemia, previous histories of severe hypoglycemia, the longer duration of diabetes, there is a more risk for hypoglycemia, and comorbid conditions like celiac disease, addison's, hypothyroidism, psychological distress, eating disorders can also act as a risk factor for hypoglycemia. Coming to exercise, moderate intense exercise can cause hypoglycemia immediately after the exercise, or it can last for up to a period of 7 to 11 hours. Hence, the blood glucose range has to be in the range between 126 to 180 milligram percent prior to the start of exercise. And also, a low pre-breakfast blood glucose, or when the child wakes up with the symptoms suggestive of hypoglycemia, we have to always suspect nocturnal hypoglycemia. And these studies have shown that a bedtime blood glucose value of less than 100, as well as a fasting blood glucose value that is less than 118, may implicate that the child must have had a nocturnal hypoglycemia on the day. So coming to evaluation and management of hypoglycemia in type 1 diabetes, it is based on the insulin action profile. First things are always first. So think about time of the insulin injection that has been taken and the action profile of that insulin, and if possible, change to multiple daily dose of insulins, analog insulins, and as well as technologies. Coming to food intake, think about timing of food intake and as well as carb content of the meal, and also the type of meal, fat rich or protein rich meal, and try to modify the glycemic peaks of the food intake to match the insulin action profile. And if the child is on NPH, you can ask the child to take a daytime snack and as well as a bedtime snack. Physical activity depends on the timing, duration, and intensity of the exercise, and it may be prudent to advise that pre and post activity CBG checks to be done. And if the pre-exercise CBG is low, additional carbohydrates can be taken, and if it is a planned activity, the basal rates can be reduced. Nocturnal hypoglycemia and as well as hypoglycemia unawareness requires increased monitoring of blood glucose, and the overnight BG pattern has to be observed in cases of nocturnal hypoglycemia. And we can modify the basal insulin regimen in case of nocturnal hypoglycemia, and we can modify the glycemic targets for children who are having hypoglycemia unawareness. And we can always think about using technologies like CGMs and sensor augmented pumps to bring down the incidence of hypoglycemia in these children. Coming to treatment of hypoglycemia, prevention is the goal and diabetic education is the backbone for it. So we need to inform the patient about how to identify symptoms suggestive of hypoglycemia. Once you have symptoms, you need to check the blood glucose, and if it is less than 70, you have to start treating yourself. Mild hypoglycemias can be treated with oral glucose in the dose of 0.3 grams per kg. For a 30 kg child, it is 9 grams, and for a 50 kg child, it is 15 grams. Avoid fat-containing foods for immediate correction of hypoglycemia, like chocolates and milk, etc. Retest the blood glucose after 10 to 15 minutes. This has to be followed with 15 grams of slower-acting carbohydrates like bread, milk, fruit, biscuits, etc. And the treatment of severe hypoglycemia, we need to give glucagon injection if available as IM or subcutaneous, in the dose of 1 milligram for children weighing more than 25 kgs and 0.5 milligram for children less than 25 kgs. Intranasal glucagon has also been approved for use in children more than 4 years of age. A single dose of 3 milligrams is sufficient. And in places where glucagon injection is not available, we have to use IV glucose bolus with glucose infusion. We use 10% dextrose at 5 ml per kg for bolus, and as well as for infusion, we give it at the rate of 2 to 5 milligram per kg per minute. And a mini dose of glucagon also can be given. The doses I have mentioned here. So after 30 minutes of this mini dose glucagon, if the blood sugar is not above 100, we need to repeat the dose with twice the dosing, and prior to shift the child to hospital emergency. So let us move on to case scenarios now. And case 1 is a 5-year-old girl child with the new onset of type 1 diabetes. She is on aspart and glargine insulin, basal and bolus regimen. And for her review visit, she had come with a CBG record, which is showing a picture like this. So she is a classical case of nocturnal hypoglycemia with a compensatory fasting hyperglycemia. So if you trace the blood glucose, it will be like this: nocturnal hypoglycemia followed by a compensatory fasting hyperglycemia. This is a typical Somogyi effect, and this occurs due to higher basal insulin rates, and the treatment is to decrease the basal insulin, glargine in this case. And also we can consider to think about adding a bedtime snack. If the same child is taking NPH instead of glargine, we have to decrease the NPH dose, night dose of NPH. And the second case is a 4-year-old female child. She is a new onset case again, only child to parents, and the child is on Lispro and glargine insulin. The review visit showed a compliant CBG records, except for less number of checks during the nocturnal time period. And as we can agree that she definitely has a pre-dinner hypoglycemia, and she also has a borderline blood glucose level during fasting. So, and there is this history of too tired while waking up. So in this case, what I would do is I would obviously decrease the lunch dose of insulin, and think about like whether she's having an activity during in the evening. And if there is so, then I would like to start the child on some extra carbs for the activities. And I would also like to use a technology, continuous glucose monitor, in this child to rule out nocturnal hypoglycemia because of borderline BG in the fasting state. And so when the child was started on CGM, her blood glucose tracing was like this. So she definitely had pre-dinner hypoglycemia, and she also had pre-breakfast hypoglycemia. Her 2 a.m. readings were mostly in the normal range. But what the finger prick blood glucose missed was the hypoglycemia that occurred in early mornings, and as well as the post-breakfast hypoglycemia. So this is the daily CGM tracing, and yes, you can see that she has early morning hypoglycemia continuously. And we have modified her basal dose. We reduced the basal dose, and we also reduced the bolus dose for breakfast and lunch. And we have given extra carbs for her evening activities. And this is how in the follow-up she had done. And definitely there is a considerable decrease in the time below target range upon follow-up. And after some time, the same child was started on the Medtronic 640G pump, which has the auto suspend function on suspend on low, or like suspend before low. So the blue ones here indicates that the moment her blood glucose touches the hypoglycemic range, it suspends before low. And whereas the red one indicates it suspends on low. So over a period of time, as you can see, like the number of pump suspensions have come down, and and the glycemic control of her got better with less incidence of hypoglycemia. So use of technology definitely reduces the time below target range, and this effect has not been proven in children actually. And the use of sensor augmented pump therapy suspends the basal delivery of insulin for about 2 hours, and this is quite useful in children who have nocturnal hypoglycemia and hypoglycemia unawareness. As we speak, like there are multiple trials going on with hybrid closed loop insulin pumps and bioionic pancreas. So coming to our third case, a 6-year-old male who is a known type 1 diabetes for the past 10 months. He is on basal and bolus regimen, Aspirin glargine, and he is not cooperative for CBG checks, and he did not reveal type 1 diabetes at school. And in this school, he will play continuously during break hours, and he has the habit of skipping the mid-morning snacks, and he has a wide gap between breakfast and as well as lunch. And one day the parents got a call from school stating that the child has fainted at school, and in the ER his blood glucose was 40 milligrams percent. So we have a child with severe hypoglycemia, and he fainted in the school. So the precipitating factors are that irregular meal habits of the child and the very active nature of the child, and the parents did not disclose the diagnosis of type 1 diabetes in the school. He is at a very risk for hypoglycemia unawareness, and the solution to this is checking CBG frequently, especially prior to mid-morning snack and as well as during the break hours. And the child has to definitely improve upon his nutrition, and this can be done with the behavioral modification like giving a smiley sticker or a star sticker whenever he completes his mid-morning snack. And also we should involve school in the management of type 1 diabetes in this child. Generally, we give medical certificate and as well as flow charts like this of what to do when there is hypoglycemia and hyperglycemia. And in this case, upon follow-up, the child became more inclined to eat and check CBG. And the school also got involved in the management of type 1 diabetes by providing more time to finish snack, and also allowed parents to check CBG during the break hours. So next is a very interesting patient, 10-year-old boy who is a type 1 diabetic for the past 1 year. He has been using pre-mixed insulin 30/70. He was presented with recurrent hypoglycemia even with 1 unit of insulin. He has been managed as per protocol in the ER, and his blood glucose got stabilized 6 hours after admission. And 12 hours after admission, his blood glucose was in the range of hyperglycemia. And we wanted to start the insulin, and this time we wanted to go for analog insulin because we thought the pre-mixed insulin is what is causing hypoglycemia in this child. But this is not the end. This is only the first admission of the child. What happened, within a month, he came for a second admission with recurrent hypoglycemia, and this time, even though he is on an analog insulin, the blood glucose started stabilizing by about 2 hours after admission, and by 4 to 6 hours after admission, his blood glucose was in the 200s range. His investigations was quite normal for the hypoglycemia, like low C-peptide levels, normal cortisol, adequate cortisol response, and urine ketones being negative. So when plotted across, like we can find out that the hypoglycemia wanes as per duration of insulin. So he was initially on pre-mixed insulin, and by 5 to 6 hours, his blood glucose got stabilized without insulin. And while the child is on analog insulin, his blood glucose got stabilized by 2 to 3 hours. So, and the investigations are within normal limit. So this led us to the possibility of factitious hypoglycemia, and this is really a signal of psychological distress. So what is the precipitating factor in this child is that the parents were too hard on the child for hyperglycemia, and the insulin was easily accessible by the child because it was kept on the door of refrigerator. And the solution is to control the access to insulin first, and the second thing is to have some behavioral modification for the parents by encouraging, coming forward attitude by the child. Last case is a 15-year-old girl who is a known type 1 diabetic for the past 6 years. She presented with recurrent hypoglycemia and required very small dose of insulin. And she also has this dark skinned appearance. So this is a child few years ago, and this the child at present. And as you can see, there is definitely hyperpigmentation. And she has low serum cortisol and proven to be Disson's disease, and her hypoglycemia got better once hydrocortisone replacements were started. So coming to comorbid conditions that can lead to hypoglycemia in type 1 diabetes, the most common condition is the hypothyroidism followed by celiac disease. Addison's disease occur in about 1 to 2% of these children, and it is diagnosed with AM cortisol, electrolytes, ACTH, and 21 hydroxylase antibodies. So the key messages in my presentation is reduction of hypoglycemia is a key component in the diabetes care. Whenever the blood glucose falls less than 70, we have to act at this point of time to prevent further fall in the blood glucose. Always think about behavioral symptoms as the symptoms and signs for hypoglycemia in a young child. And approach to hypoglycemia prevention is the only goal. Think about modifiable factors first, like insulin action, food intake, etc. And then we move on to like conditions like hypoglycemia unawareness and comorbid conditions. Treatment for mild hypoglycemia, it is oral glucose. Give about 15 grams, recheck in 15 minutes, and the blood glucose has to be more than 100 at that particular point of time. For severe hypoglycemias, it has to be glucagon injection or like IV glucose bolus with the IV infusions. And newer technologies like CGM and sensor augmented pumps definitely improve the glucose control and reduce hypoglycemia. So I want to thank my diabetic team, my diabetic nurse educators, and as well as the dietitians for providing such a wonderful care to our type 1 diabetes kids. And thank you all for your patient listening.